Please give a warm welcome to our panel. Karen's going to start things off and talk a little bit about what's going on in Kansas.
I want to talk about a few things, a few major changes that are going on for us in drug rebate in Kansas. We do recognize, most of you know that I work with Cindy LeClaire. We do recognize that you guys are hungry for as much information as you can get to be able to plan ahead and so forth. And Cindy tries to accommodate that as much as possible. We are still in a state of not quite sure, but confirming our plans for MCO Data, which I'll talk to you all about in just a little bit. But probably two of the biggest changes for us in drug rebate, besides the whole offset amount, the Affordable Care Act, where it allows us to invoice for MCO Data, drugs administered through the managed care organizations. And then also coming up at the first of the year is a program called CanCare. And what they're doing is they're moving the majority of almost all the population from fee-for-service to managed care. And that is to begin at the first of the year. Right now, the population that's sitting in managed care is about 2/3 of the Kansas population, but it's the healthier population. With this change in CanCare, most everyone, even the disabled and so forth, will be going through to an MCO. Just to talk a little bit about the whole ACA changes and managed care organizations, it says right here, we begin to intend to invoice MCO Data in mid-February of 2013. It's now looking like we are probably going to begin invoicing in November of this year for third quarter 2012 data. Now, as far as retroing back for invoices going back to first quarter 2010, we're not quite sure of our plan just yet. But again, as soon as we solidify our plans, Cindy will send out information. She'll send out like an email blast to the folks that are on her email list for drug manufacturers and so forth. You know, because Cindy likes to make sure that you're all prepared and you get as much information as you can. It's just, you know, I even called Cindy right before this meeting asking, have we solidified it yet? And we haven't been able to do that yet. But at this point, it looks like we're probably going to begin in mid-November versus in February. And again, like I said, we'll keep you informed. Our invoice types, the MCO invoice types, will be separate from the fee-for-service. There will not be an MCO invoice for each particular MCO. It's just you'll have MCO invoices and fee-for-service invoices. Invoicing will be based upon the MMIS paid dates, not necessarily the MCO paid dates. Therefore, you're going to see, and I'll talk about this in a little bit, your data is going to look really bizarre. Not necessarily, bizarre is probably not the right word, but you can't, you can't trend it like you trend fee-for-service data. It's not going to look the same, at least for Kansas. You know, I can't speak for other states and what you may see in other states, but you know, maybe for those of you who were in the last meeting that was in here, you know, the gentleman was talking about a trending program and so forth, and you know, like he was saying, maybe after 2 or 3 or 4 years, you know, when you get some solid data in, maybe you can use trending analysis and so forth, but at this point, you know, I wouldn't recommend it, and when you start receiving your invoices, you'll see why. The Kansas MCO companies, on this slide, I put down who the current ones are, at least for those MCOs that we'll be invoicing you on, which would be Coventry, Unicare, and Kansas Health Solutions. And then in 2012, when we start CanCare, the 3 MCOs are AmeriGroup, Sunflower State Health Plan, and United Healthcare of Midwest. And all 3 of those have different PBMs. And as I said, plans to invoice past data will be communicated as soon as we solidify them, which, you know, hopefully we will within the next week or 2.
And just a reminder, these slides will be available through IIR, so if you don't get every word written down that you'd like to, you can reference that.
Going on to talk a little bit, oh, I'm sorry.
On your slide where you say service date, you mean that's the same as dispense date, right?
Yes, service date is the same as dispense date. Going on to talk a little bit about the CanCare. CanCare is to serve Kansas in need with a transformed, fiscally sustainable Medicaid program that provides high-quality, holistic care and promotes personal responsibility. It's estimated to reduce our Medicaid spending growth by 8 to 10%, saving over $835 million, and now the estimates are even up to $1 billion in all state funds. The savings are expected through improved outcomes versus cutting provider fees or services, eligibility, and so forth. So, you know, it's gonna be really exciting to watch, to see if you know, we can really have these outcomes for these patients, and especially as the sicker population is moved into managed care. And again, it moves the vast majority into managed care in 2013. As far as some information that you guys as rebate folks would be interested in is the managed care organizations are required to follow Kansas's preferred drug list. They're required to pay the fee-for-service dispensing fee of $340. You know, you may see as you work with different states, a lot of the PBMs, you know, you may be looking at 10 cents or $1 or something, but that's part of what the MCOs have agreed to. The MCOs and their PBMs are allowed to use mail order and specialty pharmacies, but they're not allowed to require it. Going on to MCO Rebate Concerns, and I talked a little bit about the whole Affordable Care Act because that allows us to invoice for MCO data, and then about CanCare because you're going to see even more of our population move in there in 2013. I know several of you are waiting for our MCO invoicing data. Some of the concerns that I have, and I'm sure you guys have, is number one, the data. And we call MCO data encounter data. I don't know what you guys refer to it as, but we refer to it as encounter data. The state probably has limitations that they put on when the MCOs are supposed to submit their data and so forth. But in Kansas, we've had a project in the past several years where we've had the MCOs resubmit their data, take the data out and resubmit it. So, you know, normally with fee-for-service data, you get this nice trending from quarter to quarter. If you see, you know, any aberrancies, you know, usually you guys will reach out to us and say, hey, what's up? With the MCO data, you won't be able to see that because, you know, we may pay a claim, let's just say in this quarter, but it may have a service date back in 2010. So, you know, not only looking at the paid dates is going to be very important, but also looking at the service dates or dispense dates is going to become very important. Because, again, the MCO data can come in at any time, and at least in Kansas, we have them void and replace their claims versus adjusting a claim. You know, if you adjust a claim that goes back 2 years, then it goes back to the original invoice 2 years ago or whatever. With a void and replace, it you know, comes out of that past quarter and then is invoiced in the new quarter in which it was paid. So, you know, again, I'd like to stress, not only look at paid dates when you're looking at your data, but also the service dates too. We are talking with the different MCOs and their PBMs, the current ones and the ones that are coming up in the future, about, you know, how we deal with physician-administered drugs, what type of editing that we do, sharing our information such as our NDC HCPCS crosswalks and so forth. At least for us, we as HP, we will receive the encounter data from the different MCOs, and we will continue to do the rebate process through us. So we'll use our conversion factor, our conversion factors for both NDCs and for HCPCS. So you're not going to have, you know, different conversion factors from A and B and C. You know, if you see some aberrancy, it should be the same across the board for all of our data, fee-for-service or MCO, because it's all running through us at HP. Disputes, you know, we recognize that because we're dealing with an MCO and another probably a PBM, that there's an additional layer in the disputes. So it may take us, you know, together collectively a little bit longer to get the information or to work out disputes, but I figure we'll figure it out as we go along. Didn't know if at this point there were any questions. Sure.
I just want to be sure that I understand how you were describing that void and replace. So from the manufacturer's point of view, I think that what I heard is that we would receive a prior period adjustment, adjusting those removed units down to 0, and then the resubmitted units from the MCO would appear as, they would be included on the current quarter invoice as original units again.
Yes,
okay.
That's correct. Yes, sir.
Yeah, I was curious, thanks for bringing up about the inability to trend.
Yeah.
Can you give some insight on, I think maybe Washington would have this issue right now, and Minnesota's kind of disappeared again, but a lot of the other states aren't representing it that way, and I was curious, why is Kansas so unique in that aspect, and what are your barriers and challenges where other states don't seem to have that?
I don't know. No. I think one of the things was the whole, when they did the Encounter Data project to clean up some of the past Encounter data, that project began before the Affordable Care Act was passed, and the whole, you know, MCO piece came into play about being able to rebate those. You know, and I think as Kansas moves forward, the data, you know, the data will get better, and you know, you probably will be able to trend. It'll be more current and so forth. But at these, you know, when we get ready to invoice first quarter 10 through, you know, let's just say the present, you're just going to see some spikes and some troughs, and you know, there's going to be all sorts of stuff, and we will do our best to try to give you a heads up on what you may or may not see as the data comes out.
Well, I'm from HP. Been with North Carolina Medicaid as the fiscal agent for pharmacy services since late '96, so it's been a long time and seen a lot of changes. And the first thing I'm going to say is I'm very thankful we have no MCOs. So if you take anything else back, I've had, I'm applauding as well. So but I probably get that question every other day from some pharmaceutical company. Well, North Carolina, this is as in every other state, it's been the year of the budget shortfalls. In May, this was published in our paper, so I took it directly from the paper. We had a $205 million shortfall in Medicaid, and this was state funds, not state and federal, but 205 in state funds we were short. And of course, Medicaid says it was due to changes they had estimated going in sooner, and of course there was CMS delays in approving some of the changes. So a lot of changes we can't put in, changes in the Medicaid system until CMS approves it. And I'll give an example of one of those later. But normally when a state Medicaid agency has to estimate what how they're going to save money, it's a very quick turnaround. You know, the legislator's saying, what you going to do? And you say, we're going to do this, and how much money is that going to save? You may have 1 or 2 days to come up with these figures. And then they hold you to that. So it's a very quick turnaround, and then you have to wait for CMS approval, which delays it even further. Well, by mid-June, they said it was $75 million more than originally than the 205. So now we're up to, you know, $280 million short. Well, ultimately, we now have a new Secretary of Health and Human Services and a new Medicaid director since all this happened. So apparently, thought maybe if they get some new faces in there, they'll solve the problems, but I'm not sure about that. We do work very closely with the state's financial team as far as bringing in the rebate money. I don't know if all states have this relationship with their rebate vendor, but it does matter when you send the invoices out, because, you know, when you send the invoices out, then the money starts coming in. So if you have a state that waits till the very end of the month to send them out, you're going to get the money 38 days later. Well, we were able to work with the state, got the invoices out, I think, by May 11th, which was a record. And of course, it's much easier now with having the DDR database, being able to download the data and get it out pretty quickly. But we were able to get in $129 million in rebate money for June, which was a record. And it did help with the state's deficit issue. And as we've mentioned, North Carolina hasn't talked about going to managed care as of yet. Of course, could be rumblings that I haven't heard about. So we're looking at cutting or saving money other ways, such as cutting reimbursement and or cutting services. One of the changes I mentioned that was waiting on CMS approval was our WAC change. North Carolina went to WAC plus 7% probably about a year and a half ago. They decided to lower it to WAC plus 6, but we did have to wait for CMS approval, and I'm thinking it took around 9 months to get approval. So even though we started working on this and implemented it and was ready to go, I think in December, we just implemented that change this past August, mid-August. So, we have several months where we were not able to save that money. And this is millions of claims, so it would be a nightmare to try and adjust all those claims. So I seriously doubt that we will be adjusting claims, but if we have providers adjusting their own claims, then they would be priced at the WAC plus 6. And of course, we'll continue to look at the lower of logic, lower of SMAC, FUL, and usual and customary. Don't even get me into the FUL issues and waiting for CMS to update those. We've had a workaround in place for about 9 months now, where we allow the providers to override the FUL price because it's just not available at those prices. But we have a way of, providers report it, we validate it, and then we just put it on a special file that allows the providers to override the FUL. But if we have a state MAC on file, then they can't go over the state MAC. And North Carolina also has an enhanced specialty pricing logic, which is lower than the WAC plus 6. It's not published. It's not published mainly because the rate really can change at any time. There is a list of drugs on DMA's, our North Carolina website, if you'd be interested in looking at those drugs, but those are ones that have the specialty pricing logic applied to. Another changes that went in earlier this year is our dispensing fee logic changed. This was implemented on February 1st. Basically, we changed the way the generic dispensing fee was determined. So we actually have a dispensing fee that's based at a provider level. So we base it on the provider's generic dispensing rate. So if they've dispensed 100 Medicaid claims over a 3-month period, 50 of those were generic, then they basically have a 50% generic dispensing rate. So that would be at the lower tier. So we've got 4 tiers, the lowest starting at under 70%, all the way up to over 80%. If somebody has over 80% generic dispensing rate, they get $9 dispensing fee. If it's under 70, they have a $4 dispensing fee. So it's a wide variation. Of course, this has led to multiple questions by multiple providers about what we see as a generic in the system. We came up with rules several years ago, and we pretty much stuck by those rules. So if a generic, even though it's a branded generic, we treat it as a multi-source drug or brand drug in our system. So basically, if it has an NDA on file, it's treated as a brand drug. These rates are expected to be lowered sometime later this year or early next year, but again, we have not yet received approval from our customer to start on these changes. But when we get approval, we'll also be lowering our brand dispensing rate from $4 to $3. Another change we're looking at doing is promoting more utilization of 340B for hemophilia drugs. We do have a hemophilia treatment center in North Carolina, but they've been carving out. So the state's been working with them to come up with methodology that will work in their best interest, the state's best interest, in utilizing 340B for the hemophilia drugs. The state's not going to a sole source contract, meaning that if you're non-340B, you can still dispense the hemophilia drugs, but it will be a lower reimbursement rate than our current specialty methodology. So we still have to do a lot of work to get this in the system. We don't have the official system change request order in yet, but I know the state's working on that. And the estimated savings from the dispensing fee, lowering the dispensing fee and the 340B will be $6.6 million state funds. Again, I'm sure the state's already accounting for that money, even though we haven't started on it yet. So it's just, you do the best you can do, and you just go from there. I did want to tell a quick Bill Baxter story. I've known Bill since I've known Bill since early '97.
Yep.
We met at a dispute resolution meeting in Dallas, Texas in June. It was really hot. It was my first dispute resolution meeting. We had a very colorful pharmacy director at the
Yes.
time, and basically all he would ever say going to dispute resolution meetings was, just pay me. But
Sharon speaks the truth on that. The famous phrase, I believe, was just shut up and pay.
yeah. So I have known Bill a long time.
And I survived it. So
Yeah, that's
anyway,
right.
probably because Sharon was there.
No, we all survived it.
Okay, I think we have time for one, maybe two quick questions, or we can go on.
Yes.
With the brand and generic dispensing fee rates, the city did finally make an exception that when you do restrict the generics because the brand is cheaper after rebate, that doesn't count against the
Well, if it's a preferred brand, then that's treated as a generic in their generic dispensing fee logic. But some examples, like with inhalers where there is no generic, the providers, it becomes across as a brand drug. So unless they call the doctor to try and get it changed, then it will go against them.
Okay, great. Let's move on to the great state of Illinois.
All right, I'd like to welcome everyone for coming to Illinois to attend this. I think it seemed like it was a pretty good turnout this year. To begin with, obviously Illinois, if most of you are familiar with us, is Karen was talking earlier about trending with Illinois. Obviously you can't trend at all because our payment cycles are so off the wall sometimes. I mean, we have some quarters that we catch up and then other quarters where they hardly pay anything. So again, I know that's a problem and wish there was more I could do about it, but unfortunately I don't pay the bills. So. And with the MCO, Illinois is going toward a little bit more towards MCO. We do have a integrated care program which started about the middle of last year. It's approximately 40,000 lives that are in the collar counties around Chicago and suburban Cook County. We should be having invoices for that going out. We actually had a couple of invoices go out this last quarter for some physician claims, but we will be having, from what I've been told, we should have invoices going out this fall, third quarter, with dates of service going back to the middle of last year, because that is when the integrated care started. So as long as we have those files, we have the claims from the MCO companies back that far, we will send those out. There will be two invoices for the MCOs. There will be the MCO pharmacy invoice. There will also be an MCO physician invoice. Obviously, because of the different conversion issues, we just thought it'd be better to send two different invoices. One of the major changes that Illinois has had in the past few months is the Illinois Senate Bill 2840, which was just passed in May, which cuts $1.6 billion total from for the fiscal year 2013 from the Medicaid budget. Now this is all services, obviously not just drugs. But this is referred to as the Saving Medicaid Access and Resources Together, or the SMART Act. Some of the cuts that they're talking about in this is reducing the eligibility of certain programs and eliminating others. Illinois had a program called the Illinois Cares RX program, which has been going on for many years. That was actually eliminated. We actually have cut the eligibility on some of the other programs back closer to what the federal guidelines are for the usual Medicaid for income eligibility levels, rather than we had I think a 300% of the limit on some of those plans, and that's been cut back. They're also reducing the reimbursements to most providers by 2.7%, requiring eligible entities that are eligible to participate in the 340B program to enroll in that program, buy drugs for the Medicaid patients through that program, and pass that savings on to the state. We've also started trying to In the past, on some cases, it was hard for us to identify, especially on our physician claims, who the 340B entities were. We've been trying to clean that up as we go along, but we are also trying to get the providers now to actually put an indicator on the claim, so at least they will be easier to identify. The state's also going to be implementing co-pays for the drugs to help keep the cost down a little bit, of $3.60 on brand drugs and $2 on generics. The fifth one there is the prescription limit of 4 prescriptions per month for adults and for children. This is not a hard limit. Obviously, there are some patients that, because of illnesses, definitely require more than that, but anything over 4, they do need to receive a prior approval from the state, or at least a doctor's certification on file with the state in order to get the additional claims. And we do also have change on some of the reimbursements, similar to North Carolina. We're not having a tiered one, but we have increased the reimbursement fee on generics. It's actually going to, I think it's around $6 on the generics, or it's $3.60 on the brand drugs. That's a new change that's also going into effect to try to encourage the more of the use of the generics. Some of the other issues facing the state because of the budget conditions, the continuing state budget issues, there's definitely been a lot of talk about pension reform in the state of Illinois for state employees, and that we're still trying to wait and see what the legislature on that is going to do. Right now, we do not expect them to probably do too much until after the elections this fall before they really take that issue up again. We're also not sure what kind of effect that's going to have on the workforce. Actually, at the end of May of this year, we had a very large reduction in the workforce for our state agencies because a lot of people were trying to get out because of talks on possible reforms that were coming up and hoping to get out before the reforms would go into effect and hopefully not be affected by them. But a lot of the reforms they're talking about actually will be covering everybody that's retired. Contract negotiations between the state and the unions that represent the state employees will also probably have an effect on the workforce. There's a lot of major issues that are still going on there. As our contracts ran out at the end of June, because one of the things they're talking about is cutting the pay for a lot of the staff quite deeply. As I say, we did have a lot of retirement at the end of fiscal year 2012 because people trying to get out of those projects. That does shorten the staff that we do have available to continue with other projects we have going on with the state. Personally, in my area, I have one programmer that, I used to have 2 programmers that supported our main billing program for Medicaid rebates. They both have retired. I have one person now that is now supporting that program who had very little knowledge of the program, is still trying to get me to teach her how to do her programming. I mean, she knows how to program and everything, but it does slow the whole process down because when you have only one person instead of 2, obviously you don't have the resources there to really keep up with some of the changes that need to be done. I don't have any more really the specifics. I was going to try to bring some more of the specifics about the SMART Act and how it was going to affect certain programs, but unfortunately I forgot to bring that with me. So.
Well, thank you. I have a Jeff story.
You do?
As you might imagine, just to make sure we're all on the same page and everything, we had a phone call and just to coordinate between us. And Jeff, as you can hear, is kind of soft-spoken, and the first time that he made reference to the SMART Act, I thought he was talking about me. And so when he clarified it was ACT, then we got along fine after that. But anyway, we have a few minutes for questions, except for the gentleman at the back.
Jeff, for you, just want to confirm that there would be, you mentioned that providers, for 340B providers, must use the 340B program. They can't take the ADAP option. Is that correct?
Okay, the ADAP, I'm not really even sure. As I say, I only work on the rebates. I'm not that sure of all the policy stuff. So what that is, I'm not even positive of. I hate to show my ignorance on that, but
But all eligible 340B have to buy and have to buy through the 340B program, correct?
that is the main intention of the legislation, to the best of my knowledge, yes.
Okay, thank you.
Jeff, in case there's some follow-up on that, I think we have contact information. Would you be willing to take an email from somebody?
Yes, very definitely.
Yeah, okay, good. We had a couple other...
I know this is my last one too.
Close.
I just didn't hear what you said about when you're going to invoice the MCOs. So I think you said next quarter there will be 2 invoices, and it will be fee for service and physician assisted. It's back to, I didn't get that one.
Approximately the middle of last year. I think the integrated care program is really the only current MCO program that we have that includes where the drugs are going to be included in the MCOs. We do have some other MCO programs in the state that carve out the drug benefits, so the physicians or I should say the pharmacies do have to bill the state directly. Integrated care is a little bit different, so it's just the 40,000 lives that are going to be affected in this, and that's really all should be seeing on the invoices.
Karen says she has a follow-up point, and if I don't let her do that, she's going to tell Cindy LeClaire on me, and I don't want that to happen. So, Karen, please.
No, I was just telling Bill I had an observation. Ian, you know, it's interesting as the three of us sit up here and talk about the different things that our state's doing. Like, we're moving to managed care, full managed care, where we don't want to cut services or fees or whatever, and it's proposed to save about $1 billion. And you know, you guys are cutting different services or fees, and you know, proposed to save millions or billions of dollars. So you know, it's going to be interesting to see how things turn out in the next couple of years or so, as far as you know, as far as what goes on. And going back to the gentleman that spoke at noon about the ACOs, you know, if you happen to attend that was rather interesting. And especially the comment at the end about, you know, is it really rebranding? Because I'm trying to figure out, okay, if MCOs are required to have good outcomes, and it sounds like ACOs are, you know, and they're going to get rewarded, it's just, you know, all these different acronyms and things to learn and how we're all going to do things. It's just, you know, I'm just up here talking now, so.
Okay, I think we have time for one more quick yes or no question. Whoa. All right. How about you, sir, at the back? You have another one.
Sharon, can you comment a little bit about what it means to follow the state EPL and the MCOs, how that be enforced? Will there be a chance for duplicative rebates from manufacturers standpoint? You know, there's sort of that Oregon way, and then there's the Texas way, and then there's kind of this Ohio thing that really didn't have too well with 65%. But basically, I guess I'm looking, you know, are you going to prohibit the MCOs from negotiating with manufacturers if the ask is to pay a supplemental rebate on MCO utilization through the new fee-for-service contract?
I almost think that your best bet might be to put that down in a question that we could forward to our customer over at the state, and that way, you know, you can get a response that you can work with.
That, by the way, wasn't a yes or no question. Listen, I think we're out of time at this point. Thank you very much for your interest. The folks will be available out in the lobby. Thank you.